All right, guys, so this is the continuation of module number 4. These are the same objectives that we had with the first half of this video. So we will be completing these with the rest of this video. So we discussed in the first half of this video, we went through some of those changes, the normal things that you might see for baby and all the normal reflexes. So now we're going to start taking care of a baby that might have issues and talk about why we need to or what we need to do to take care of these babies. Okay, so when we're talking about hypoglycemia in babies, um, number one, we cannot poke babies' fingers, okay, because they're very, very tiny. We can destroy those nerve endings, so we actually use their heels. So we do a heel stick blood glucose. Um, we'll do those on any babies that are SGA or LGA. Remember from last video, we talked about the Ballard score and how we come up with if the baby is small for gestation age or big for gestation age. So any of those babies that are small or large for gestational age, and any mother that was diagnosed as having diabetes, either it being gestational diabetes, regular diabetes, that baby's going to be getting blood glucoses. Babies that are jittery, so more jittery than just the Moro reflex. So remember we said Moro reflex, the babies will kind of wave their hands back and forth. So babies with low blood sugar will be jittery, or babies that have a high-pitched cry. So any of those things, we're going to check a blood glucose. So pretty much anytime we have a baby that's acting differently than what it should be acting, one of the quick things to do is check a blood glucose. Okay. So a normal is anything 40 to 80 on a baby. So anything less than 40, basically what we do is we'll do it on a regular AccuCheck. And if it comes up less than 40, then we're going to go ahead and draw a small vial of blood and send that to the lab for confirmation. Typically, it's really hard for those AccuChecks to read the very low levels that babies may have. So you may not even get a reading if it's less than 40. It just depends on the machine that you're using. Um, so how do I fix a low blood sugar? The easiest way is to feed the baby. Okay, so as long as baby is able to be fed, and I say that because babies with respiratory issues, babies that are on oxygen, they may not be getting PO feeds. So the that's a whole different kind of a thing. You know, you may have to start an IV with some dextrose in it or something for those babies. But your baby that's out on the unit, if they have a low blood sugar, the easiest thing is to feed. Okay, so get baby to breast or give baby a bottle of formula. Um, we're going to do either one of those things. Okay, that's the easiest way to fix blood sugar issues. Now, when we start talking a little bit about hypothermia, so for hypothermia, it's really easy for these little babies to get cold. Remember, we talked about when I'm inside mom's uterus, I'm in at least a 98 kind of environment, 98-degree environment, right? So now I'm on the outside, and most people don't live at a 98-degree environment unless we're outside, because we typically use air conditioning. We keep our house cooler than that. So babies need extra layers. Okay. Babies that are thin and don't have a lot of fat may need an extra layer. All right. So I usually tell my moms that um, in dressing a baby to give baby one more layer of clothing than what you have on. Okay. So in the summertime, mom may wear shorts and a t-shirt because it's very hot. For a baby, if they are going to be, especially in the air conditioned, you may want to put like a onesie kind of a thing on them, or if they're wearing also a summer outfit because they're going to be outside where it's warm and then go inside, just have mom bring a blanket with them. That way, when they go in the air conditioning, you can cover baby up. Um, Putting a hat on baby's head is the very quick way to um, keep baby warm. We lose a lot of heat through our head, through our scalp. Keeping baby dry is super important. So drying that baby off when it is after it's born, and then we'll put baby skin to skin with mom. Mom is the best place skin to skin for baby because mom will help keep baby warm and it helps with the bonding. Okay, so we're going to take baby's temp when they are born, and then again every 4 to 6 hours, or unless we feel like baby is either cool or too hot. If baby's temp goes below 36.5, 4, we'll put baby in a radiant warmer. So those nice big contraptions that you see. Um, and what the way those run is there's a temperature probe that will stick usually to baby's abdomen, and that takes baby's temperature. And then the radiant warmer is set to either increase or decrease to keep baby at a nice normal warm temp. Sorry guys, I'm videoing this at home and my dogs have to bark at everything that happens. Um, So any heat loss can lead to um, a decrease in glucose because now I'm going to have to use brown fat, which is fat that deposits for the baby that helps keep the baby warm. So if I have to start using this brown fat, then I'm going to be losing more weight. My glucose level is going to go down. Okay, so that can be a big problem for our babies. When we start thinking about babies having hypoglycemia, some of the risks for being hypoglycemic is moms that are diabetic, babies that weigh greater than 4,000 grams or are large for gestation age, post or preterm babies, small for gestational age, babies with a low temp, an infection, respiratory distress, baby that's had to have some sort of resuscitative measures, and birth trauma. So some of our signs and symptoms, and you'll see as we go through these, some of these signs and symptoms are the same for babies for several different issues that they may be having. Okay, so basically the idea is to know if you've got a baby that's doing one of these things, um, while we have to deduce which one it is, what's the one that we're trying to take care of, we're going to run through a whole list of things. Okay, so our baby's jittery, hypotonia, meaning he's floppy, he's not flexed, irritability, apnea, lethargy, temperature instability. Well, that pretty much applies for all the different kinds of problems that we may have with babies. So then we're going to go through our list of things. I'm going to check an O2 sat. I'm going to do some vital signs. I'm going to check a blood glucose. So that's kind of the way that this works as far as our babies. Okay, so this slide just shows you some pictures of where we're going to poke a baby to do some blood sugars. You'll notice that we're going to be poking the sides of the foot, either on the inside or the outside. Um, and the middle picture here shows the nurse drawing blood from that foot into the small PD tube. So it's just like the small tube, the regular tubes we draw adults' blood in. These are just tiny ones. And you take the lid off and you collect the blood this way and then put the lid back on. And then the one on the far right shows the little AccuCheck foot poker that we use. So you don't use the kind that you use on an adult on a baby. These actually do a small slice on the foot instead of just a poke. So it's a bit longer, but it doesn't go as deep because we don't want to cause any kind of nerve damage on this baby's foot. So this slide just goes through how you do a blood glucose, or how I do a blood draw on a baby with their heel. So typically the best thing is to warm up that baby's foot. So we do various things. They do make foot warmers that are small, little plastic, and they have a chemical in them. You pop them or, squeeze them, and the two chemicals mix, and it makes a warm kind of a little foot warmer thing. You put that on baby's foot, and it has a little piece of a sticker on there, so you can kind of make a little warm foot warmer there for them, like a little shoe almost. Honestly, the thing that does the best is if you know you've got to get even say a CBC and a BMP out of a baby's foot, is to put that foot warmer on, and then even sometimes put a regular diaper on top of that and kind of wrap it up and let that foot get nice and warm before you get ready to do your stick. So number 3 talks about putting a warm, moist washcloth. You just have to make sure if you do use a washcloth, that it's not too hot, and so that it doesn't cause a burn on baby's foot. Okay. So you will poke the baby's foot in one of those side areas, and then as long as you allow that area to get some blood flow to it, you can get a good bit of blood drawn. Of course, you want to do your CBC first because that's the draw that you don't want clotted. If it's clotted, you have to redraw it. So it'll bleed really well, usually through that first tube. The second tube can be a little bit clotted. If you're doing a CMP, that's usually okay. They can still get what they need from that. So I'm not going to discuss everything on this slide. It is a process that you have to learn how to do, and if you're going to work with moms and babies, or work in the ER, you may need to know how to do that. So those are all important things to learn, but not necessarily something you need to memorize. Okay, what do you do as the nurse to take care of the baby? So we're obviously going to monitor for signs and symptoms of hypoglycemia. We'll assess our blood glucose levels with our monitor. If baby's low, we're going to get mom to breastfeed or formula feed the baby. If for some reason baby cannot take a PO feed, then I'm going to give either an IV of dextrose or a buccal dextrose gel that can be used for babies as well. That's relatively new for me in my practice. So typically we would go ahead and just get an IV started on a baby if there was some reason why they wouldn't feed. Okay, typically if a baby's not wanting to feed, there's probably something, either their blood glucose level is nil or none, or there's something else going on too, so you're going to need an IV anyway. Um, and then we're going to make sure we keep baby from getting cold. We need to remember, if we're working on a baby, that especially with a newborn, we keep the baby in a warm environment. So we're working under a radiant warmer, or you have they have large pads that actually can go underneath baby. It's very similar to the foot warmer. It has chemicals in it, and you mix them together, and it makes a large warm pad. Put that underneath baby. Um, so keeping them warm is really important. So a hint for NCLEX: anytime a baby has a respiratory rate over 60. Okay, so my baby is jittery. Um, I do a blood glucose and it's less than 40, so it's 35. I'm getting ready to see about feeding this baby to raise that blood glucose, but then I do the respiratory rate and it's 66. I cannot feed that baby. All right, it's breathing too fast. It might aspirate on that fluid. So we want to make sure that we do something else to feed this baby. Either they'll drop an OG tube down and feed baby through that, or we'll more likely start an IV and let baby get glucose that way. So symptoms of a sick newborn, um, like I said before, this kind of are the same throughout anytime we talk about a baby that is sick. So you're going to have a baby that may be lethargic or difficulty waking them up. They may have an increase in temperature, but also some of your really sick babies, their temperature is going to drop instead. Sometimes in our septic babies, that'll be one of the first things that we notice is a low temp. They may be vomiting, not just spit up, but actually vomiting up everything that they've eaten. Green liquid stools, refusal of feedings. Usually it's several in a row. It's okay if they refuse one time, um, especially if they're breastfeeding. They may just be sleepy and not ready to eat. But once I get into a second feed, then I'm going to be more concerned about that. Okay, so there are 4 different ways that babies can lose heat and get cold. So the first is through evaporation. So that's why we're going to make sure baby stays dry when they're initially born. We're going to dry them off. The second one is through conduction. So that's when baby touches a surface that is cooler than their body temperature. Their heat is used up and they can get cold that way. Convection from cold air around them, or then radiation from them being close to something that where cooler air is coming in. Um, Newborns use that brown fat, they metabolize it to keep themselves warm. So you can understand that we have a baby that's preterm or small for gestational age. They don't have that brown fat to use. So I can't burn that to keep myself warm. So we have to be very careful with our babies that don't have a lot of extra fat on them. So what can I do to prevent cold stress? So I'm going to dry baby after birth and make sure that they don't lose heat that way. I'm going to keep wet blankets away from them. Um, I'm going to put a hat on baby's head, do skin to skin with mom. Use pre-warmed blankets or clothing. So if baby is very, very small or preterm, I'm going to make sure I have blankets that I use out of the baby warmer. You can sometimes put their little sleep outfits, the little onesie kind of things, underneath the radiant warmer and let them get warm before you put them on them. Make sure you swaddle them in a warm blanket. Before we put baby in the radiant warmer, we want to go ahead and turn it on and let it get warm. You don't want to give a bath until baby's temp is stable. Typically, we would do this at about 4 hours of age, but now they have found that they prefer to delay the first bath because it's better for mom and for baby for bonding. We want to keep baby away from air vents. We don't want to put them underneath a ceiling fan. Keep them away from outside walls or windows that may have allow cool temperatures to come in, and try to so those are our biggest things that we want to do for preventing of cold stress. Okay, so talking about cold stress, that's when you have excessive heat loss. It leads to hypothermia, and then babies start to try to use other things to warm themselves up. One of those is burning that brown fat. So consequences of cold stress are hypoglycemia, metabolic acidosis, respiratory distress, hypoxemia, and weight loss. Okay, so some signs and symptoms of cold stress, like I said, these will become very familiar. So temp at or below 36.5 or 97.7, cool skin, lethargic, pallor, tachypnea, grunting, hypoglycemia, hypotonia, jitteriness, or a weak suck. Okay, again, talking about signs of respiratory distress. Those sometimes are a little bit more easy to see because you'll have a baby that's cyanotic. I'm either breathing too fast or too slow. Um, I, I'll see retractions of the chest wall, grunting, flaring, and baby will be floppy, so hypotonic. Um, so we want to teach mom and dad how to take both the axillary and a rectal temp, um, because they both are important. We don't do rectal temps a whole lot anymore. We used to do them the first temperature once baby was born, but they've gone back to where we're not doing those very much at all. So we just want to be cautious when we're teaching um, how to do a rectal temp. Okay, so now we're going to discuss some of the things that will go on prior to discharge. So a hearing screening will be done. This is one of those mandated tests that all the states are requiring prior to baby go home. Basically what they have found is if we go ahead and screen babies for hearing loss when they're in the hospital, we can follow up then once if they fail the hearing screening, we can follow up outpatient, and then they're able to treat babies that do have hearing loss at an earlier age, which hopefully helps with the development of language and all those other milestones that we want them to meet. So there's a couple different kinds that they do. The autoacoustic test is actually done. They put a little probe in baby's ear, and it does a few different beeps, and it's trying to gauge whether or not there's any kind of movement in the inner ear, in that eardrum. So that's what that one is testing for. There's also a brainstem response. With this one, they'll put several probes on baby's forehead and neck, and they'll test through that way to see if babies have a response to that sound stimuli. Now, of course, this has to be done in a quiet room. Any baby that has excess vernix blood or amniotic fluid in that ear, it can interfere. So usually we'll do a hearing screening. If baby fails, we'll wait 12 hours or so, because usually we'll go ahead and start doing those at 24 hours of life. We'll do another one in 12 hours or so and see if we can get baby to pass before they go home. If they do not, we say, this doesn't mean your baby's actually deaf. This just means that they may still have fluid in their ears. So they'll rescreen them in a month and then go from there. Okay, so circumcision is one of those procedures that might be done before baby goes home. So we'll talk about that just a little bit, and then some of the parent education that we need to do prior to mom and baby going home. Okay, so that'll be the removal of the foreskin with a scalpel. Then we'll put the petroleum gauze or around the site to keep that from sticking to the diaper, like we talked about in our other lecture. So after the procedure, we're going to assess our site for 15 minutes, every 15 minutes for the first hour, and then check on it every 2 to 3 hours. These babies can bleed quite a lot, especially if something gets nicked. So we want to watch for that. Any bleeding larger than the size of a quarter, we're going to make sure we tell our physician about. Acetaminophen, we usually go ahead and pre-dose babies with acetaminophen, and then they can have it every 4 to 6 hours as needed. There is a neonatal pain scale. It's called a NIP, NIPS scale, NIPS. So you can, go through that and assess baby's pain and decide if they need pain medication every 4 to 6 hours. Then the next thing that's going to be very important is that first void. They should void within the first 24 hours, within 24 hours after the procedure. If not, we need to follow up with someone, our physician, to make sure that all is okay. Okay, so some patient or parent education for circumcision. We're going to make sure that we instruct mom and or dad or significant other to watch for bleeding or signs of infection. Um, we tell them usually to leave the site alone. You don't want to wipe it with a wipe unless the stool has gotten on it. If there's gauze placed on there, they should just leave it alone and that it will fall off as that petroleum gauze dries up. We want to make sure that we are putting diapers on, but to kind of make them loose. You don't want them to be too tight. And then they need to notify your physician if they have bleeding larger than a quarter, any signs of infection, or if baby has not voided within 24 hours. Typically, if baby's had a circumcision, they're going to stay until they void and not be sent home without making sure that that's been done. Okay, so cord care. What am I going to teach my patients, my parents about for cord care? So that cord is going to start drying up. It should fall off within 2 weeks, typically much quicker than that. We'll take the cord clamp off at 24 hours unless it has the ID number on it. If it has the ID number on it, they're going to leave that on until you go home. Um, we will tell them that that cord is going to turn from that whitish, kind of yellowy, clearish color to black as it dries up. Um, and we want to make sure that we're watching for signs of infection. So we're going to make sure that when we put the diaper, it should be like the baby in this picture underneath that cord site. Some diapers are made with a little cutout so that it doesn't rub that um, umbilical cord. But you can do the same thing with a regular diaper and just fold down the top and still get the same effect without having that little notch cutout thing. If the cord is dirty, you're going to clean it with water and dry it. And then if we see any kind of bleeding, have any foul smelling drainage or redness around the skin, any fever, we're going to contact the physician. Okay, so Kangaroo Care, also called Skin to Skin, we've talked about that a lot. So we like parents to do skin to skin care with baby. It does help stabilize their temperature if they're able to do that with mom. Um, Usually it helps correct their heart rate and their breathing because they relax a little bit. It helps with increased weight gain, time in a deep sleep, and decreased crying. It also is really good for moms that are breastfeeding because they're able to have some of that bonding time together. Um, Benefits for mom include decreased stress, increased bonding, and increased milk supply. If mom is not available for some reason, dad can do skin to skin care, and it works really well with keeping babies warm and with the bonding process. Okay, so a period of purple crying, purple being an acronym for these different stages of crying for babies. So the important thing about this is that we teach moms to never shake a baby because that can cause massive um, problems in babies. Um, Brain damage, sometimes even death from having a shaken baby. So sometimes babies just cry. Okay, so understanding what kind of crying is going on, um, thinking about if it happens every day in the afternoon, does it happen every single evening? Um, Having mom remember that they need to just jot those things down that way they can speak to the pediatrician about it when they go in to be seen. Okay, so back to sleep is the SIDS prevention. It comes out through March of Dimes and through your health departments. So we always want to make sure that we're placing baby on their back to sleep at any time that they are sleeping. I know old school moms, grandmoms might tell you that babies need to sleep on their bellies because they sleep better that way. And while that may be true, to decrease the risk of SIDS, they need to be on their back to sleep. Okay. Um, Now, once they can turn over themselves, then you're able to leave them in that position as long as they can move themselves in the bed. So if baby's old enough that they're rolling around in the bed, you don't need to be monitoring all night, that baby has laid on their belly. Um, if as long as they're able to move around, then you're good to go. Um, After baby is um, able to move from back to front, if baby's moving and rolling over, we don't want to keep them in a tight swaddle anymore. Usually the best thing is to use one of those sleep sacks. that they have where you just zip baby up into it. You don't want to have a lot of other things in the bed. We used to use crib pads that would go around the outside of the crib so baby doesn't bang their head on the side. Um, you don't want to use those anymore. You don't want to put any kind of toys or stuffed animals in the bed, lots of blankets, any of those things where baby might can get their face into that bedding and not be able to get their face out of there in order to breathe. So this slide just continues the discussion on things that we're going to talk about as far as SIDS and SIDS prevention for babies. Um, of course, we want to make sure that anything that you're placing your baby in to sleep, crib, bassinet, portable crib, that it all meets the Consumer Product Safety Commission standards. Um, you're making sure if you're using an older crib that the slats on the crib are closer together. They usually say you should not be able to pass a can of Coke through the slats, so the slats shouldn't be any wider than that. The problem was is they were farther out on some of the older cribs, and babies were able to get their heads hung in between, and so that's not a good thing. You don't want baby to sleep in the bed with you. There have been a lot of issues with that where mom or dad put baby in bed and you roll over on baby and not realize it. So if you want to co-sleep with baby, they make specific safe places for you to purchase where you can put baby in the bed with you. Okay. You don't want baby to sleep on a couch or in a chair. You need to be able to maintain safety around baby. Um, some of these are um, kind of common sense, but we still have to mention them to moms and dads. So don't smoke around baby. Breastfeeding helps reduce SIDS. Pacifiers that are not attached to a string are able to be used for babies. Um, you don't want babies to get too hot at night. So, and then one of the other things is we do want babies to have tummy time, have time to lay on their stomach. So we can do that when we're able to be able to supervise them. So you don't want to do that when you're not able to be there and monitoring what they're doing. Okay, car seats, super important. Got to have a car seat in order to take a baby home from the hospital. Some hospitals want to see you put the baby in the car seat. Some places want you just to bring the car seat to the floor so we can verify that you have one. An important thing to know is that car seats do have an expiration date. You need to look at them and make sure that they are within date. If a car seat's been in a car accident, it should not be used again. Um, there are places where you can go for a car seat check. Um, there used to be that they did them at Lakeshore. We would have them once a month car seat checks. Before you could go to the highway patrol station and they would check them. Just make sure you call and check on those things before you go out. Some of the health departments are doing them. So basically what you do is it's a drive-through. You drive up and they make sure that you've got the seat in appropriately, that baby's buckles are all in the right place. Um, so just to make sure that baby is actually safely in their car seat. So lastly, there are 5 S's for soothing babies. This is just a way of trying to remind mom or dad or significant other of how we can soothe baby if you have a fussy baby. So you can swaddle baby. You can put baby on its side or stomach, but only if you're there as an adult. Shushing the baby, just by that I'm saying holding the baby and shh, 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 shh. You're just making that noise. Um, I did see that they are now making little contraptions that actually play that sound, that shushing sound. If your baby likes that sound. Remember, I've been inside mom for 10 months and I'm used to the noises of the blood flowing through that placenta, and it makes that kind of a shh 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 noise as it flows through there. So that's comforting to me. Swinging or sucking, so sometimes a pacifier can help. So you just want to make sure if you're going to swaddle baby that we swaddle baby the correct way. I will show you how to do that in class, or at least the way that I do a swaddle. There's a few ways to do it. Everybody has a different one. I try to do it the easiest way I can. So we will talk about that a little bit in class.